Welcome to episode 16 of the ProPA podcast. I'm your host, Prof. G, and today we're continuing our pneumonia series with a deep dive into HIV-related pneumonia. This is a high-yield topic both for PANCE and clinical practice, and one you'll encounter in patients with HIV and AIDS. In this episode, we'll discuss the most common pathogens based on CD4 count, clinical presentations, evidence-based management strategies, and some essential clinical pearls. Stick around to test your knowledge with vignette-style questions at the end. Let's get started. First, let's start off with the kinder patho. What is HIV-related pneumonia? HIV-related pneumonia occurs due to immunosuppression from the virus HIV, with increases in susceptibility to both common and opportunistic pulmonary infections. The degree of immunosuppression, typically measured by the CD4 count, is the most critical factor in determining the type of pneumonia an HIV patient is likely to develop. As the CD4 count declines, you will notice that above 200, patients are prone to community-acquired pathogens just like the rest of us. Below a CD4 count of 200, opportunistic infections such as Pneumocystis, jirovecii emerge, and below 100, disseminated fungal infections and viral pneumonias become more common. So who gets HIV-related pneumonia? Well, patients with untreated HIV or poor antiretroviral therapy or ART adherence are the highest risk for opportunistic infections. Prophylaxis for PJP and toxoplasmosis is critical when the CD4 count drops below 200 or 100 respectively. So let's look at some of the common pathogens by CD4 count and break it down. So a CD4 count of greater than 200, we're going to see more of the community-acquired pneumonia pathogens, just like in the general population. These are the same that affect the immunocompetent individuals. We're going to see Streptococcus pneumoniae. This is the most common cause of community-acquired pneumonia in HIV patients. Other pathogens can include Haemophilus influenza, Mycoplasma pneumoniae. Then when we look at a CD4 count between about 200 to 100, we're going to see opportunistic pathogens. And the most common one we are going to see in this category is going to be Pneumocystis jirovecii pneumonia, or PJP, formerly known as PCP pneumonia. This type of pneumonia has a more gradual onset of dry cough, dyspnea, and hypoxia. And on imaging, we tend to see a bilateral ground glass opacity on chest x-ray or on CT. On labs, an elevated LDH is a hallmark. Now, patients with a CD4 count less than 100, we're going to see disseminated fungal and viral pathogens. So these type of pathogens include Cryptococcus neoformans, which typically presents with meningitis, but pulmonary involvement is also possible. So think of the buzzwords of encapsulated yeast or pigeon droppings. We can also see cytomegalovirus or CMV, and pulmonary involvement can have some interstitial pneumonia and systemic symptoms. It's also associated with retinitis and some GI involvement. Now, a CD4 count less than 50, we're going to see more of the rare opportunistic pathogens like Mycobacterium avium complex or MAC. And this causes a disseminated disease, which is more common, presenting with fever, weight loss, and night sweats. And pulmonary disease is a little more rare. So the clinical presentation symptoms really vary by the type of pathogen, but common features will include fever, a dry or non-productive cough, and dyspnea. Symptoms also include some systemic symptoms like night sweats, weight loss, or lymphadenopathy. And let me give you some of the key clues by pathogen. So PJP, we're going to see that gradual onset of dry cough, exertional dyspnea, and hypoxia. Community-acquired pneumonia, sudden onset, fever, productive cough, pleuritic chest pain, just like the immunocompetent population. For Cryptococcus, we're going to see the systemic symptoms with or without meningitis. Now, physical exam findings tend to see crackles, diminished breath sounds, signs of respiratory distress. Remember, this is still pneumonia. And we're also going to look for those extrapulmonary clues like skin lesions in those specific types of fungal infections. So, how do we work up these patients? Well, we have to know that they are immunocompromised first off. And once we know that, our suspicion is going to be elevated for these more opportunistic type infections. So for diagnostic testing, we're going to want to do sputum analysis and cultures for bacterial and fungal infections. We can run a beta-D-glucan for elevated fungal infections like PJP or cryptococcus. We can also do a cryptococcal antigen or an LDH level, which is elevated in most PJP cases. For imaging, again, we're going to want to start with a chest x-ray. Oftentimes these patients get CTs as well. For PJP, we're looking for that bilateral ground glass opacity. We're going to look for community-acquired pneumonia pathogens, more a lobar consolidation. And for CMV, we're going to look for diffuse interstitial infiltrates. Now, management-wise, for community-acquired pneumonia, we're going to treat like immunocompetent patients, but we also need to consider the need for a broader coverage. Just because their CD4 count is above 200 doesn't mean that they're not still susceptible to some of the more opportunistic type infections. So generally the treatment for community-acquired pneumonia is ceftriaxone plus azithromycin or levofloxacin. For the Pneumocystis jirovecii patient for PJP, the first-line treatment is going to be the trimethoprim sulfamethoxazole or Bactrim for 21 days. And we're going to want to add in corticosteroids if the patient is hypoxic. Now, for cryptococcus, for the severe disease, we're going to be giving the patients amphotericin B and flucytosine, followed by fluconazole for a maintenance dose. For cytomegalovirus, we're going to treat with ganciclovir or valganciclovir, which are antiviral medications. And we're going to want to give prophylaxis for opportunistic infections, especially if the CD4 count is low. So when our CD4 count is less than 200, we're going to want to start our patients on prophylactic trimethoprim sulfamethoxazole. Also, when the CD4 count gets below 100, we're going to want to start treatment for toxoplasmosis prophylactically. Now, some quick clinical pearls. For HIV patients with a CD4 count less than 200, always suspect PJP. If symptoms are mild, consider getting some chest imaging and you're going to look for that interstitial disease. A beta-D-glucan is an excellent screening tool for fungal infections, especially when combined with other clinical findings. And my third clinical pearl for you is always ask about prophylaxis compliance. Many opportunistic infections are preventable. So as far as the book med versus the street med, now the book med is going to go strictly by the CD4 count, and the diagnostic testing is going to be really critical in guiding the treatment. However, on the street, many HIV patients with pneumonia are just treated empirically. They're treated for community-acquired pneumonia and PJP, and this is why we are waiting for those diagnostics to come back. We always want to keep these opportunistic infections on our differential. All right, now let's look at some quick review questions. So question 1, we have a 35-year-old woman with HIV, a CD4 count of about 180, who presents with fever, dry cough, and worsening dyspnea over the past 2 weeks. A chest x-ray shows bilateral ground glass opacities, and her LDH is elevated. What is the most likely diagnosis? Is it A, Streptococcus pneumoniae, B, Pneumocystis jirovecii pneumonia, C, Cryptococcus neoformans, or D, cytomegalovirus? I'll give you a few seconds. If you said B, Pneumocystis jirovecii pneumonia, you are correct. The combination of a CD4 count less than 200, bilateral ground glass opacities, and an elevated LDH is classic for PJP. All right, question 2. A 40-year-old man with AIDS, a CD4 count less than 90, presents with fever, cough, and weight loss. Blood cultures grow encapsulated yeast. What is the best initial treatment? Is it A, amphotericin B plus flucytosine? Is it B, sulfamethoxazole with trimethoprim? Is it C, azithromycin plus ceftriaxone? Or is it D, fluconazole? I'll give you a few seconds. If you said A, amphotericin B plus flucytosine, you are correct. Encapsulated yeasts points towards cryptococcus, which requires amphotericin B for initial treatment. All right, I want to thank you for joining me in today's clinical medicine brief on HIV-related pneumonia. We discussed the most common pathogens, their presentations, and management strategies based on CD4 count. Stay tuned for more episodes, including future topics on infectious diseases, PANCE prep, and clinical pearls. If you found this episode helpful, hit follow and turn on notifications so you never miss a new episode. And as always, this is the Pro PA Podcast, where future pros in medicine are made. I'll see you in the next episode.